So we have muscle and mesh. On the right side, you have alcohol-associated liver disease, ALD. If patients have both of them, then we tell like Met-ALD. And we have specific etiology for steatotic liver disease or cryptogenic ones. So since it's a very very recent change in this presentation, I'll use these interchangeably, like muscle or NAFLD, MESH or NASH, because our most recent guideline is also using old terminology like NAFLD and NASH. So how can we put the diagnosis of NASH? So we have first some kind of imaging or biopsy showing some fatty accumulation, steatotic liver disease, and then we'll ask about the cardiometabolic risk factors. If there's no cardiometabolic, if there is cardiometabolic risk factors there, then we'll ask if there is any other cause for steatosis. So if there's no other causes like alcohol, then it's muscled. If there is another cause like alcohol, it may be Met-ALD. And if there's no cardiometabolic risk factor, then we ask about any other causes. If there's no other causes, then it will be cryptogenic steatotic liver disease. And if it is yes, then we'll look for the specific reason. These are the cardiometabolic risk factors, criteria for steatotic liver disease, like BMI, fasting blood glucose, blood pressure, triglycerides, and HDL cholesterol. So we know that MASH is a progressive liver disease and have associated with many other comorbidities, very high range. On the left, you see a simple steatosis. On the middle, you see the MASH, which has steatosis and inflammation. And on the right, you'll see that you have the, okay. So on the very right, you see the fibrosis. When you have fibrosis, it may be from F1 to F4, F4 meaning cirrhotic. We call it as F3 and F4 as advanced fibrosis, and F1 and F2 as early fibrosis. And I want to stress on that bidirectional arrows between the fibrosis levels. So you can see if you give appropriate treatment, the fibrosis may improve from one step to down. NASH with increasing fibrosis may end up with cirrhosis, and that may end up with HCC, hepatocellular carcinoma. But even though you do not have any fibrosis, you may end up with cirrhosis, and you can see the increasing rate of that on the slide. And we have also stages of cirrhosis, which we can look at that with hepatic vein portal gradient pressure. If it is between 6 and 10, this is compensated cirrhosis. When it becomes between 10 and 12, then you had the varices, but they're not bleeding. And if it is bigger than 12, then you have variceal bleeding or ascites or hepatic encephalopathy or jaundice, meaning decompensation. So the clinically important portal hypertension is here important to stage the liver cirrhosis. Very shortly about the pathogenesis, you see lots of arrows here, but you can see in the very middle free fatty acids, which is in the middle of the MASH pathogenesis. So fatty acids are cause for lipotoxic species and causing liver injury through the endoplasmic reticulum, mitochondria, and cytokines, and last apoptosis. Here, this shows where are the targets for treatment in this pathogenesis. I'll plan to show the medications which are targeting these points. So you'll be very you have seen lots of time as things, this diabetes and other things are getting increased prevalence, not in the Western world, but on the whole world. This is for diabetes. From 2004 to 2019, you see the prevalence is increased. This just like adults age 20 or more. And this is together with obesity and diabetes. If you see that, it's getting darker and darker with years. And Texas is also here getting darker. The economic burden of mesh is really very astonishing, like more than $200 billion. So that's a big amount. And we should never forget that this is a multi-system organ. It's surprising to understand that this is a liver condition, but the most common reason for that is like cardiovascular deaths and malignancy. This is a study from Southwest, like San Antonio. They offer for the screening colonoscopy patients to look for their livers, and if they have steatosis, they also offer some biopsies. What they find is the NASH, like 12.2% of these patients, and out of these, 2.7% was stage 2 and 4, meaning advanced fibrosis. Just 8 years after that, you can see the fibrosis stage is increased, doubled. Here, 2.7 to 5.9. So it's the fibrosis is also increasing. And here for the US middle age cohort, you can see how high the MASH and muffled prevalence in diabetic people. It's important for us, perhaps Latino Hispanics are also very high with the NASH and muffled. We know that if you have muscle and if you're having fibrosis, then the all-cause mortality will increase. You can see on the very low part is the population cumulative events, meaning any cardiovascular events or liver-related events. And as the fibrosis increase here, you'll see how the rate is increasing. This is also same for this one. From F1 to F2, the survival is decreasing very abruptly. And major advanced liver outcomes, MLOs, are also increasing with increasing fibrosis stage. So fibrosis is something very important. You can see the mortality about the muscle. Only 8% is directly related with liver disease, but as this population is mostly diabetic and obese, you can see the cardiovascular risks are very high and the malignancy is also very high. For diagnosis, the routine and gold standard is like liver biopsy, but it's not innocent and it has many backgrounds. So today, what we are trying to get is having some diagnostic tools which are non-invasive. So there are 3 kinds of these that we can reach at the moment. One is like imaging. The others are scores derived from blood tests, and we have some proprietary tests. For imaging, I will emphasize FibroScan, vibration controlled transient elastography, and also from the scores, 5-4 is very important, which is very reachable for everyone, especially for the rural area primary care providers or anyone else having this very basic labs. Why is fibrosis so important? Because it is directly associated with the all type of liver-related mortality and morbidity. As the increasing fibrosis stages, you can see the complications and mortality is increasing. And on the other side, if you treat that fibrosis, then the liver-related events will decrease. So we know this historically from hepatitis B at the beginning of 2000s. We have lamivudine and then the others. And we saw that the patients are regressing, improving with their fibrosis. And then we have the hepatitis C like that. The hepatitis C patients are treated and their fibrosis are improved. And now we have lots of candidates for MASH to treat, and we expect to see the same thing. So diagnosing the fibrosis and steatosis, and also using that not only for diagnosis, perhaps for controlling throughout the management, treatment may be also important. Is what we call is vibration-controlled transient elastography. This has a probe here giving a small vibration to your liver and then measuring the propagation rate of this wave. And at the end, we have two measurements, which is stiffness, the first one, like in the units of kilopascal, and the other one is CAP score. This is for steatosis, and this is for the kilopascal one. The stiffness is for fibrosis. This is very highly negative predictive value, having very high predictive value if it is lower than 8, meaning that if you have a measurement of lower than 8, it means you exclude advanced fibrosis. That makes a huge relief for the primary care providers. And we know that this vibration control transient elastography also predict major adverse liver outcomes, like with increasing kilopascals from 8 to 12 and more than 12, you can see survival will decrease very significantly. The other imaging technique, the other three will be on MRI. The first one is MRI-PDFF. This is for the steatosis, the fat measurement. So this is not only the diagnosis only, but now with resmetirom, we can use it with the monitoring of the treatment. So with this MRI-PDFF, when you begin resmetirom, you can control if the patient get any benefit from that or not. We have another MRI. This is corrected T1 MRI. In that, we have the millisecond measurement, and if it gets higher than that number, then it is highly risk for NASH or MESH. So this is also predicts the MALOs, so it is also very helpful. The last thing is also elastography like VCTE. This is also elastography, but done with MRI. Here for this modality, we have different cutoffs. So still this is kilopascal, but we have different cutoffs for that. For different cutoffs, we have also good prediction of liver outcomes. As we see with increasing kilopascals, we have decompensation. The other important one, I told about the vibration control transient elastography, and the other one, which is very easy to reach, is 5-4 score. This you can see with AST, ALT, and platelet count with age can get you the score there. And this is also, there is a low cutoff and high cutoff. The negative predictive value of low cutoff is very high. You see 95% here. And also you can see the high cutoff is very specific. So this can say that you do not have advanced fibrosis with very high negative predictive value, or you say that you may have advanced fibrosis. In between, we have some defect here. So it is also associated with long-term outcomes, so it's a very useful score. If you use the vibration control transient elastography and add some labs here, then you have another score, AGILE 4. This is even more accurate than transient elastography. So this is a proprietary test. This is like a blood test. You send the blood and you get the similar low and high cutoffs, and it is really showing very nice correlation with the liver events. As you see, for every non-invasive test, we have an indeterminate region here. If we use more than one, then you can squeeze that indeterminate area and will increase both the negative predictive value and the specificity. Like if you combine 5-4 with VCTE, meaning FibroScan, then the result will be much more appropriate and accurate. So classically, if we pass through the treatment, this was the classical way we go for the treatment of the muscle or mesh. That includes the overweight management, including the exercise and also diet to lose some weight. On the other side, we should also treat all the comorbidities, including the obesity, diabetes, dyslipidemia, hypertension, and sleep apnea. And it works. If you lost weight like 3%, it begins to improve your steatosis and if you increase that weight loss to 5%, it may help with the inflammation. Even with 7%, you can have some resolution with NASH. And if you lose more than 10%, then the fibrosis get also improved. So caloric intake reduction is important, weight loss is important, exercise, and of course, alcohol is another cause for the fatty liver disease. We should stop or at least decrease the amount of alcohol consumption. We know the importance of bariatric surgery, especially in severe obese patients and diabetic patients. It helps for certain. We know that at 5-year point, if you look for the fibrosis, in 84% of the patients, we got some NASH resolution. And also, in 70% of these patients have improvement with fibrosis. So for the new medications we use, I want to show that targets we want to heal with the MASH treatment. One is fibrosis improvement. On the other side, we have to improve insulin sensitivity. We have to resolve the NASH, and we need some lipid benefits. The best medication will be just in the middle. But because of the heterogeneity of this pathophysiology of MASH, probably one medication will not be enough. So GLP-1 glucagon-like peptide-1 agonists are in use for some time for obesity and also for diabetes. We know that there is no GLP-1 receptors on liver, but if you treat it through other systems, then the liver will also get benefit from that. So these are the studies that had been completed up to now, not only for diabetes, but also for muscle or MASH. And we have much more here ongoing studies to treat the MASH. One of the best known ones are semaglutide. And with semaglutide, we know that there is some benefit for the MASH patients, and the efficacy is, safety is good, which very well known gastrointestinal adverse events. And new one here, not only the glucagon-like peptide-1 agonist, but also a dual agonist like gastric inhibitory polypeptide. Tirzepatide is also very quickly having these studies, research studies, and probably will get an approval very soon. An old drug here, very cheap, but still useful, pioglitazone, also known to be useful, not only for steatosis, but also inflammation. And in some studies, research studies, it's proven to be good for the fibrosis. This is a very good picture here. So that shows all the candidate medications for FDA approval for MASH. All the guys with parachutes are already dead. The others are trying to climb this high mountain. At the very top, you can see resmetirom, which gets the FDA approval, and some others very near to it. And they're very low, and that slide tirzepatide is just like beginning, but now it's somewhere like semaglutide. So we have a graveyard full of candidate medications. Let's talk a little bit about this resmetirom, which is a thyroid hormone beta agonist. It has some different ways to affect through the lipid mechanisms in in the liver. It increases xenophagy and also beta oxidation, enhances mitophagy, which means the autophagy of the senescent mitochondria, and it also decreases inflammation and increases the cholesterol clearance. This is the phase 3 trials for resmetirom. It helps with NASH resolution, and also it improves the fibrosis. Side effects are tolerable. We have a practice guideline for that. You see, for the cirrhotic patients, it's not recommended if the patient VCTA, transient elastography, is very high, like higher than 20 with the FibroScan, and with the MR elastography higher than 5. And if we have a concomitant active liver disease, continuing excessive alcohol use, or active thyroid disease are the contraindications. What is recommended is, like with non-invasive tests, if your stiffness is between 8 to 15, then it's recommended. Otherwise, you may also have a liver biopsy. It's not easy to get the liver biopsy for these patients. And in between, it's up to clinician's decision. So you have to monitor these patients for thyroid function, lipid profile, and also hepatic panel. And at 1 year point, you just control the response. And if you think that with non-invasive tests, I talk about the MR PDFF may be used for that, or you can use these elastographies, either MR elastography or vibration control one. So at 1 year point, if you do not get any response, then you stopped it. There are other candidates very near to approval, but not yet approved. One is obeticholic acid. This is a farnesoid X receptor, and it's already been approved for sclerosing cholangitis, primary sclerosing cholangitis. And phase 3 studies shows improvement in fibrosis. Safety, we have some issues with the safety. Lanifibranor is peroxisome proliferator activated receptor, and it shows to be effective for fibrosis and also NASH. And this is a good area, this fibroblast growth factor 21, FGF21. They may have a good candidate. We have two types of them. One is efruxifermin, and it shows a very beneficial effect. Very recently, they completed the cirrhotic NASH patient trial. So I think it is very hopeful for us to get these medications in a near time. The other FGF21 candidate is pegozafermin. It also, like the first one, both helping fibrosis and NASH. This is an interesting one. Like if you get the pioglitazone and get its stereoisomer, then you have this PXL605, 065, then that is also very helpful. So if you turn that targets and try to look which drug is affecting which part, you can see here. These are the current candidates on the very top of this mountain I showed. You see this resmetirom here in the middle, pegozafermin, efruxifermin, lanifibranor. These are good, but we can get semaglutide or tirzepatide between the NASH resolution and insulin sensitivity area, and obeticholic acid for the fibrosis improvement. So we are hopeful for the future. Still, probably one medication will not be enough. We need multiple pathophysiological pathways to treat. So here is the multiple medication type of research studies done. They're ongoing. And this is the last part of my presentation. So I have, I think, still time, like 5 minutes. I'll be a little bit fast. So it seems to be very crowded here, but it's more important for us, the internal medicine group, family medicine group, and the primary care medicine group. So if we think like that, primary care, non-GI hepatology care, and GI hepatology care, and either setting care, we have to be, as I said in the beginning of the presentation, we have to be cooperate very nicely. The cardiology, weight management, psychology, and nutrition should be included. And here I have to emphasize the telehealth services to increase that coordination may be helpful, especially between the primary cares and like GI, maybe endocrinology, cardiology may be also implemented to there. It will be very helpful, I think. So let's start. We have a fatty liver patient just we had with imaging like ultrasound. The easiest and reachable test to do is 5-4. Remember, we have a low cut point and high cut point. If it is lower than 1.3, it means that you can exclude the advanced fibrosis. So let's do it. If we do the 5-4, and if it is higher than 1.2 or not, we're looking for that. If it is not higher than, then we exclude advanced fibrosis, meaning that we can follow this patient in primary care settings. At that point, we should look for the cardiometabolic criteria if the patient is diabetic or pre-diabetic and or having more than one of these adult cardiometabolic criteria, then we can have a 1 or 2 years period of reassessing. And if it is 5-4, we can reassess with 5-4. And if there is no diabetes and no risk factors like 1, then we can do the 5-4 in 2 to 3 years. So that was the first part, easy part. But if we have higher than 1.3, let's first think the 5-4 is really high, meaning higher than 2.67. Then this is a good reason to refer to GI. Or a patient have a little lower, but have increased aminotransferases with persistency, then we can also refer them to GI. If it's between 1.3 and 2.6, the intermediate zone, which we're not so good, then, as we said, we can do a secondary assessment. In our conditions like Lubbock, we can reach vibration-controlled transient elastography like FibroScan, or you can order ELF one. So this is you can see the FibroScan or the ELF here. They still have this low and high cut points here. If the cut points are low, it means no fibrosis, then primary care providers can reassess that either 1, 2, or 2 to 3 years. If it is intermediate or high, then refer it to GI. After referral, this our part, we look for the secondary risk assessment. If it is low risk, then we can reassess these patients by ourselves. If it is high risk, we may consider liver biopsy or we suspect cirrhosis. If it is cirrhosis, we'll manage the cirrhosis. And if it is, like liver biopsy consideration, we will look for the staging of the fibrosis. For all the patients, they recommend metabolic risk functions to be controlled and alcohol should be stopped. So take-home messages like MASH is a potentially progressive type of MASLT. These are multisystemic diseases. There is a huge economic and quality of life burden of these diseases. These are the most common cause of liver disease, cirrhosis, and liver transplantation in the world, and still increasing. We are lucky that we have good non-invasive tests now, so diagnosis and the monitor of the disease management can be possible. And luckily, we have new treatments now. So thank you very much. I think we have some time for questions over the Zoom or from audiences.
When do you start screening for this?
Yeah, we had, sorry. We were thinking that someone will mediate that questions. Okay. So the Zoom partners cannot hear the questions, that's why.
Okay, so the question asked was, when do you start screening? When do you start screening?
Yeah, that's good. For the primary care setting, anyone with obesity, diabetes, prediabetes can be screened. And if you have incidentally have a finding in the imaging showing any steatosis, then you have to go on with these guys. Any other questions? Dr. Sherman?
Metabolic patients, many will have mildly abnormal liver function tests. They're either assumed or confirmed to be hepatic steatosis. Other than managing risk factors, which of course we do in treating the lipids, how do we know which ones to be worried about? We need to do the quantitative assessments that are suggested to predict those who are going to fibrose, or is there another way to be concerned?
So could you repeat that? It's hard to do that.
Just to summarize that, like other than managing like risk factors, like what other tests can be done qualitatively?
So that's the cardiology asking the question. So we know that the main reason for the MASH and MASLT for that is cardiovascular diseases. So it's always advised to go on with the recommendations currently done. We have to follow these. So we can do as the hepatology part, we can do the quantitative tests like non-invasive tests and may think if we have better options for treatment, we can go from there. So I know that with lots of cardiometabolic risk factors, these guys this little elevation in the AST, ALT may not be seemed so important, but it is also having some part. As I said, as we have better treatments, then we may go on and think to qualify that better. Is this an answer for that? I don't know. Thank you. Yeah, Kenneth? One more.
The geographical graph, it kind of seems like there may be a trend or correlation between genetics, because some continents seem to have a lower prevalence of steatosis compared to Western continent. What do you have to say about that?
Yeah, genetics has certainly some effect on it, but don't forget that not only the genetics, but the diet, cultural diet, and also exercise. These are also inherited for the same environment. But genetics certainly has impact on it. We have some different mutations. I showed it in one of my slides, like PNPL10. We have some certain genetic mutations that may happen on fatty liver. I think that's all. Thank you for your attention. Thank you for joining here. I think Dr. Lanke will close that.
Dr. King, thank you for this excellent presentation. And we like to give a token for this excellent presentation. Most of all, I want all the, whoever has give your feedback, because your feedback is most important to make this, better presentations. So for just go in, just get this QR code together, and please and we really want your feedback. Thank you. Okay.
Also, there is a faster way to redeem your CME credits. If you just text claim 39617 to that number, you can just get checked in and you will get an evaluation link. There's also, yeah, also a QR code.